I thank everyone for getting up this early in the morning to listen to some math. So I'm going to talk about risk management, these changing CLIA specifications and what it really means in the laboratory for risk of failing your proficiency testing. So my disclosures, I am accepting an honoraria for this talk, and I am the CLSI president, so I will be mentioning EP 23 as part of this talk. So our objectives are to assess the quality of laboratory tests. How do we do that? I will define 6 sigma metrics and the impact of changes in the CLIA PT criteria and what that means for laboratories. To consider the risk of changing quality specifications and lab performance. So quality. Our laboratory assesses quality, and physicians rely on quality results from the laboratory. But how do we measure quality in the lab? We assess analytical performance of our instrumentation to meet medical needs. This is fitness for use. In other words, does the test actually meet the medical criteria to make a decision? And we assess that 2 ways. One is bias, that's systematic errors that lead to shifts in performance from one point in time forward. Could be a problem with calibration, standards, reagents, your blanks, your controls. We also assess imprecision, repeatability. If we test a sample multiple times, we all know we're going to get different results. So what is the spread of those results? And that's imprecision. So we can estimate test performance by combining bias and imprecision to calculate a sigma metric based on total allowable error limits. This combines both bias and our total allowable or total analytical error, bias and systematic errors. So bias is our systematic error, we can see here, and our random error, which is the spread of data. In terms of combining this is our total analytical error, which combines bias and 2 standard deviations. Our limits on this are in red bars. So this is our total allowable error. That is the medical criteria for determining quality. We want our analytical performance within that total allowable error limits. And there's where you can see our bias, our random error, and within the red limits. So Six Sigma is an assessment of both bias and imprecision. And we calculate that from our total allowable error. We subtract bias and divide by our imprecision. And state of the art is really Six Sigma. That is factory quality performance. That is less than 3.4 errors per million tests. So world-class quality is what we desire for all of our tests. When we think about bias, we think about imprecision and total allowable error, it sets us up for a quality budget. In other words, if we have a total allowable error of 10%, we can then assess our bias and imprecision in analytical performance within that allowable budget, that 10%. Let's take a look at how this impacts sigma metrics. So here's our sigma calculation. Remember, it's total allowable error minus bias divided by the coefficient of variation. If we have an analyte concentration, our control at 3, assay precision or imprecision is 2.2%. Our bias of 6.7 within a total allowable error limit of 10, we calculate a sigma metric of 1.5. If we have better precision, 1%, that raises our sigma metric up to 3.3. If, however, we lower our bias from 6.7 down to 2.7, we also raise that sigma metric. So you can see how this changes based on that allowable error budget, our assessment of our performance. You've seen the biological variability databases. This one came from Nichols publication, and they provide an estimate of desirable specifications for imprecision, bias, and total error limits for your analytical performance for different analytes. Using these metrics, we can assess the performance of our analyzers in our laboratory. We moved from one manufacturer to a new manufacturer in 2012. So after bringing that analyzer up in 2013, we assessed 1 year's of performance in 2014, October 2014, using total allowable error limits of CLIA compared to more stringent allowable error limits of RICO's publication and the Royal College of Physicians in Australia. So 3 different performance specifications. And we color-coded this at 3 different levels of quality control for different chemistry analytes. You can see albumin, alkaline phosphatase, ALT, and so forth. Optimum performance was green. That is greater than 6 sigma. Good performance was in yellow, and poor performance was in red. So just looking at color coding these, you can see albumin at the very top. If we use very wide limits, CLIA, we're assessing this as either optimum to good performance, versus if we use tighter stringency, the RICO's publication, we're poor performance. So, sigma metrics, we compared 2014 to 2016, and we said, okay, operators now know the instrumentation better. Are we going to get better performance? Is it dependent on the operator, these automated equipment? And what we see is really sigma metrics are fairly stable over time. The biggest difference is your total allowable error limit. If you have tighter limits, you're going to get an assessment that is poorer performance. Sigma does vary, and you see it varying from different concentrations. So at lower concentrations or higher concentrations, you may have different biases, different imprecision, and that changes your sigma metrics. Sigma also varies by analyzer. We had 5 chemistry analyzers, and so we assessed sigma metrics for each of those individually, combined them to get a mean, and that's what you're seeing, is the mean, and in parentheses, the range that we saw of sigma based on the variety of different instrumentation that we had. So based on this, we could predict a quality control strategy, but if we do it individually by each different analyzer, we're going to come up with different quality control strategies because the sigma metrics are different. So I would recommend, really, if you have a group of analyzers, take the more stringent approach, use the lowest sigma to define your quality control strategy. This gives us operation specifications if we think about sigma metrics. Here we're plotting on the x-axis allowable imprecision as a percent against inaccuracy on the y-axis. And you can see the different lines of performance for defining different quality control strategies, whether it's 1.2S, 1.2.5S, 1.3S. Basically, how you read these, if you're down close to 0% accuracy, percent imprecision, you're on solid ground. You're greater than 6 sigma. That's your green area on this chart. However, if you're less than 3 sigma, you have a wide inaccuracy bias, wide imprecision. You're up in the deep water, which is the dark blue. And so if you actually assess this on 2 different analyzers, these are Abbott analyzers, C16,000 versus a C8000, These are architect analyzers. You can see a line of 2 sigma performance going straight down the chart. And you can plot where the sigma metrics are, and you can see most of them are down in the solid ground, the green area. But we do have a few that are sort of in that in-between. Magnesium, CO2, direct LDL, sodium, chloride. These are sort of in that in-between area. These are the ones, these analytes that we want to have a QC strategy where we pull in more levels of QC, maybe more frequent QC levels. Maybe we use tighter rules. Instead of using 1-2S rule, we go a little bit tighter, maybe instead of 1-3S, a 1-2S. You can see the difference between C16,000 at the top versus C8,000 at the bottom. Magnesium pops up again in sort of that in-between. CO2, urea. So differences between analytical performance based on different analyzers, even from the same manufacturer. So some of the sort of Six Sigma QC rules of thumb. If you're greater than Six Sigma, you can use fewer QC, use 2 levels of QC which meet the CLIA regulations, and wide limits, maybe 3.5S, to prevent false alerts and troubleshooting, spending a lot of time troubleshooting in the lab. If you're at the bottom, less than 3 sigma, you want to use maximum QC that you can afford in the laboratory. Maximize your preventative maintenance, your function checks, deploy your most trained and skilled employees. So, we see these changes, and you heard John talk about the new analytes are added for PT testing, as well as more stringent limits. What does this mean? It means if you keep the same QC strategy, you're going to risk performance issues on PT, risk failing. So the impact of CLIA changes. Let's consider 2 different tests. Alkaline phosphatase. The old total allowable error limit of 30% now is tighter, 20%. So if we have a QC mean of 33.45, our peer group is running around 33.62. That calculates a bias of about 0.5%. Our CV, or imprecision with this control at this level, is 4.5%. So let's plug this into that sigma equation. We calculate world-class performance at 30% total allowable error, 6.6 sigma. However, our tighter performance now, lowering that total allowable error to 20%, we're now estimating our performance as marginal. Same with glucose. If we have a glucose right at the cutoff for diabetes diagnosis, 123, our peer is reading 124.45, gives us a bias of about 0.68%. If that imprecision is around 1.8%, and we take an old total allowable error limit of 10, we're estimating our performance is pretty good. It's 5.2. However, the new total allowable error limit of 8% brings us into marginal performance. So we need to reassess what is our risk of failing proficiency testing based on these new CLIA changes. And I will say it's somewhat confusing. This is the new CAP checklist. This is going to be coming out later in October, November. And they give 2 different criteria for performance for hemoglobin A1C. If you were judging against your peer group, which is your methodology, you can use the CLIA limit of 8. But the NGSP program, National Glycohemoglobin Standardization Program, is an accuracy target-based program, and they use 6%. So again, you're seeing changes in specifications, and that's going to risk failure if you don't estimate what's going to happen or the impact on your laboratory. There are resources to help you assess this risk, and I would recommend looking at EP23. There are new guidance. This was just published a year ago in the fall, new examples. So that will help you in terms of assessing your risk. Let's use an example of this. Molecular point of care testing. We implemented molecular point of care during the pandemic for COVID respiratory viruses, flu, for instance. The manufacturer recommends use of positive and negative QC to validate new reagent lots. In accordance with local, state, federal, or accreditation organization requirements, additional control runs may be performed. That's straight out of the instructions for use, the manufacturer recommendations. But what about environmental contamination? We are putting a molecular device out there in the emergency room, and it is being run by nursing staff, by anyone under the sun who basically is picking up a sample. Are they going to carefully transfer liquid from the swab and the viral transport media into the cartridge? Are they going to get it all over the place? So, yes, if you get small amounts of DNA or RNA on countertops and you go through a PCR reaction where you amplify that many million-fold, very small amounts of contamination are risking a false positive. So we actually said, the package insert says, due to the high sensitivity of the assays, contamination of the work area with previous positive samples may cause false positive results. Handle samples according to standard laboratory practices. These are not laboratorians. These are clinicians out there in the field that are taking time out from seeing a patient to actually run a test. They want to get back to their patient. They're going to rush through this process. So clean instruments surrounding surfaces according to instructions provided in the cleaning section. Good laboratory practices and careful adherence to procedures specified in the instructions for use document are necessary. Wear gloves. Use laboratory coats. Eye protection when handling samples and reagents. Gloves must be changed between handling samples. Reagent tube. Control kit to avoid contamination. So we took this as this is pretty high risk, that we could get false positives out there. So what we implemented was an environmental control. Outside of the recommendations of just test every new lot that you get, we're going to now test every operator's technique. So we want them, when we initially put that out there, to run quality control at least once a week during the initial months that we implemented this to make sure we were getting positive and negative from every operator. They knew how to run the test. And in addition, we put in environmental control, implemented basically taking viral transport media, taking a blank swab and swabbing, after we wetted that swab, swabbing the surfaces of the counters, the door handle of the room they were using, the keyboard of the instrument itself, the lid. And if we got a positive, we knew they were contaminating the environment. Our recommendations in the policy were to change gloves between samples, only handle one sample at a time, clean all of the surfaces after each sample, just to ensure that they weren't getting carryover. Lo and behold, things worked very well with this. This was our risk management table, and you can see in yellow the risk of contamination, and we implemented those environmental controls, despite the fact that the manufacturer didn't have recommendations like this. That was something additional that, as an institution, we implemented. So we conducted a risk assessment. Our quality control plan was additional quality controls, this environmental control. After we implemented that, we assessed how well is this really working. And in fact, in our clinics, the clinic staff, outpatient clinics, walk-in clinics, we didn't see any environmental controls. They were following the policy in that. Where we ran into problems was in our emergency room. They were rushing things. They basically, multiple times we popped up 3 times in the first couple of months of monitoring, we popped up with false positives. So that told us something's happening with their technique in that particular site, that we needed to go back and have more education, look at them a little bit more stringency. So think about the change in your total allowable error. Think about how that's going to impact your proficiency testing, and monitor your failures, your frequency of your failures, to think about, do I need to put additional controls, additional frequency of my controls into effect? So in conclusion, the changing CLIA PT total allowable error limits are going to affect your PT performance. You should reassess your risk of failing PT. You need to change your QC ranges. Maybe you need to tighten the QC ranges. Need to add additional QC or alter the frequency, or look at your medical tolerance and the needs of the clinicians and patients. CLSI EP23 provides a resource for assessing a laboratory's risk in a world of changing quality specifications. I'm going to turn this back over to John. I want to thank you for your attention, and I will apologize. I do have an award I'm getting today, so I have to bow out at about 8:15. But if you have additional questions, you can always contact me by email, and I'll get back with you. Thank you.